Wonderful. So now I think we discuss in the order of the talks that we have. The questions are, and we have also questions online, that's true? Or
Yep.
what's the, okay, that's perfect. But let me start, Jonas. In the Gothenburg and the screening, you can all use the microphone here. I mean, we're all here in front, whatever is, so everybody can gather for questions. Yeah, we just kind of start in the order a little bit. What do you think is a good starting age? I mean, some of the studies are ongoing. I think in ProBase we reported in age 45 we really don't find a lot of cancer. Yeah, it's really little, but maybe the baseline PSA value will become more important in the next decades to come. What's your take home right now if you would advise on a health authority perspective where not every patient is an individual, but we are looking at the big group and try to implement screening maybe on a broader scale?
If you speak entirely of screening, which I mean is the methodology for a population, not for individuals. I mean, there are individuals who need early start, men with the family history and so on. But for screening in a population, I think 50 or maybe even 55 is the most beneficial. We made an analysis published in European Urology a few years ago, and we found very small advantage of starting at 50 compared to 55, so somewhere in that age group.
Okay, thank you. And then my next question to you and Vero would be, I mean, we learned that MRI is really beneficial. We also know that some patients, even with aggressive disease, are below a PSA threshold. I mean, when I started, we used to use PSA 10 as an absolute indication for biopsy. Then we had this gray zone between 4 and 10. Now, I mean, our German guidelines will say 3 is the threshold where we biopsy, but there are publications maybe we even lower that thresholds and then do an MRI to find out can we agree on a threshold for performing MRI? Or do we say, well, we always take the PSA density into context even before doing the MRI?
I agree. We do not actually know what is the most optimal PSA cutoff for going for an MRI. I think there are several studies going on, and we have the third arm in the Gothenburg 2 studies, which evaluate the PSA cutoff of 1.8, the Stockholm 3 is 1.5. So I think the future screening program probably have a lower PSA cutoff, probably have more biomarkers complementing the PSA test to identify the risk population where we should go on with MRI.
One comment about MRI, and I think we don't know that PSA cutoff. And one study which is interesting is the Reimagine Risk Study, which was published in BMJ Oncology. And it's the healthy patients getting an MRI. Half of the patients with significant cancer had a PSA of less than 3. So we don't know the clinical significance of those patients, but it's interesting. So I don't think we know what that PSA cutoff is.
At the same time, the lessons we learned from the ERSBC and the Göteborg 1 study was that those detected at repeated testing, I mean, we had 3 as a cutoff, very few of them actually died from prostate cancer. The majority of men who died in the screening arm were men who not participated or men detected at the first screening round. So we still have to know.
Hey, sorry, for one more question, then the lady behind. So what's I mean, now we talk about population and then acceptance or participation rate. I showed you that DRE, I mean, it's not a good test, but the acceptance rate was bad. The invitations we send out for ProBase, so young, healthy men in their best lives, 1 in 10 roughly comes if you invite them. So what's your perspective if we design something perfect? How do we get it to the people?
I think DRE should not be in the first way of screening because it may scare men. I think a blood test is optimal, and we have a participation rate which goes up to around 75–80%. And when they have an elevated PSA, 90 to 95% comes to the follow-up testing with DRE, biopsy, and so on.
Okay. Thank you. So the lady at the microphone.
Thank you. I'm Nora Chavez, a clinical oncologist from Mexico. And I would like to know, for you, how many core biopsies are the bare minimum and how many are the ideal?
Okay. Yeah, we will discuss that in a second. Alberto, you wanted to comment on the PSA threshold, I think.
I mean, the number of biopsies or the
No,
PSA?
no, PSA threshold, where you said you wanted to comment.
No, I mean, I actually another comment on,
Okay.
on if I may.
You may. We have time, that's good.
So I'd like to ask, if possible, Europe, I mean, Vero is here, and the reimaging study, or actually the proof of concept of using MRI instead of PSA for future screening programs. Does it really make sense? I mean, I always cite when your study, and when also there is a cost-effective assessment that was published on Annals of Oncology, a great study, that is not cost-effective, but PSA still may miss some cancers, visible cancers, I mean, clinically significant. So is there any setting when you foresee in the future use of MRI instead of PSA for screening programs?
If I may reply to the Mexican lady first, I would say that we use 4 cores for targeted biopsies. If they are negative in the first, then we do fusion biopsies in the second round with 6 biopsies with the direct fusion technique. According to this, I think it's too much resource consuming to let all men have an MRI. I see no point of that, because we know that men with low PSA, and we will get the publication on this on EIU now in a few weeks, those who have a very low PSA, they have a very low risk of being detected with prostate cancer. So I think resource consuming, but I think we need better blood markers compared to PSA alone to identify the risk population who needs an MRI.
Really good point. So look, I think the multi-parametric MRI 30 to 40 minute scan is not practical in everyone. MRI scans need to get shorter and more streamlined, and there are sequences which are 5 to 10 minutes which can produce information as good as a multi-parametric MRI from some of our early work. So I think a shorter, more streamlined scan may make it more feasible. The second point is who needs an MRI, and as part of the Transform screening study in the UK, we'll be investigating a range of strategies based on PSA thresholds, genetic profiling, in order to see, or just MRI, to see which of the strategies is feasible, and then in the longer term, in the second phase, we'll be looking at more prostate cancer-specific mortality, things like that. So we'll ask the question and hopefully give you an answer in 20 years.
Okay, so we will stay there because of the question from Middle America. I mean, in our panel, I showed the slide, the majority said, well, there is still value in systematic biopsy. I fully agree with Jonas that if you do systematic biopsy, we definitely find more indolent disease, or what we believe might be indolent disease. We don't know what's 20 years down the line if we start screening early. But systematic biopsies, what's your take, Vero, as one of the MR heroes? Do you still see value, or do you use it in practice or not? Because, I mean, I was surprised that our panel said, well, I do systematic biopsy. So what's your take?
Well, you might call me a villain after my answer, but look, I think systematic biopsy, practice varies around the world. When I try to run my trials, I find I can't run a trial without offering systematic biopsy as an option. I think it depends on what your goals are. If you look at an MRI lesion and you believe that an MRI lesion confers prognosis and you should treat on basis of that, well, you shouldn't be doing systematic biopsies. I think I showed some prognostic data about the visibility of a lesion determining your prognosis and treatment being tailored to that. If you believe that, then there's no point in doing systematic biopsies. However, if you want to maximize non-visible Gleason 3+4 with systematic biopsies, you will increase your detection by about 10%. And to that question at the back, I think if you're just doing a targeted biopsy-only approach, you need at least 4 cores per lesion. I think that's fairly evident. But for the systematic biopsies and how many you need overall, I don't think there's a minimum. It depends whether you do them or not. And now you add perilesional biopsy into the equation, I think it's a different question. And I think the guidelines change to me, probably quite early for saying perilesional biopsy should be done. But there's lots of trials which will be reported to EAU on this, so we can look at that.
So I'm happy that we now have a lot of questions
May I
standing
just
there.
give one short comment? I think it's very important that if we should convince health authorities around the world to implement prostate cancer screening, we must decrease the overdiagnosis with prostate cancer. Otherwise, they will say it's unethical. I discussed with so many, and the only way to decrease overdiagnosis quickly is to abandon systematic biopsies.
I agree, but we are still missing, and I think not biopsying is the easy task, and getting rid of systematic biopsy is like the next frontier. At least our panel is not there yet, but we certainly very much appreciate your point. So one more question to you, Veru. I mean, the PRIME study showed that we do not need DCE, but you need high-quality MRI. I think that's a machine thing. We can, if the patient is compliant, do that. But radiology training, I mean, do we need a certification, or if we roll this out in large scale? We did not discuss AI for radiology. Glenn told AI in pathology, but this is still something. I mean, we are in the panel. We have radiologists now here in the first session. Unfortunately not, but what's your take on reader experience and reader training AI in this field?
Yeah, reader experience is absolutely critical. If you look at some of the early trials I ran to now, 10 years later, the experience level of all the radiologists in the study has gone up. You can add 2 zeros onto the number of scans the radiologists read every year. So I think experience is increasing, but it's not just about experience, it's about having feedback, having a setting in which you can present your MRIs, see what the pathology is, and learning as a centre. And I think everyone learns from doing that. And the second part of the question was?
Well, that's AI, whether you see a role in AI.
Yeah, I think AI has an important role. We know that to reach the expert level, it's difficult, it takes training. We know there's a shortage of radiologists predicted, certainly in the UK, and I'm sure around other areas in the world. And good thing we've got another study coming up called Paradigm, which will evaluate the role of AI in prostate cancer detection. I think it's really important to look at that, to try and offer a high-quality diagnosis wherever you are. We know there are disparities in healthcare across countries, and hopefully that will help address that.
Okay, so Nick first, and then Jochen.
Yeah, and I thought it was a fantastic session. So I just wanted to highlight something. So I chaired a commission for 4 years for The Lancet on future trends in prostate cancer. And just to make the point, the majority of prostate cancer cases and deaths do not occur in high-income settings. And there's going to be at least a doubling of prostate cancer deaths globally in the coming 15 years. And just in that context, if you go to sub-Saharan Africa, for example, or Malaysia, or a whole load of different countries, the majority of men are diagnosed with metastatic disease. And so we've been talking about PSA testing in essentially very healthy, very health-conscious populations like Scandinavia. But even within high-income countries, so like we've just done a project which I'm presenting a bit of tomorrow, we've gone to areas of London, for example, where the rate of metastatic presentation is above 25%. If you do PSA testing in that setting, you find really high rates of diagnosis. So the comment is, or the question is, are we screening are the right people in the trials, even within high-income countries? Because I would contest that they actually are not. And so I think one of the things that we need to address, which we haven't discussed at all, is how you get screening to the people most at risk of death, which is people from, in the UK, for example, from any ethnic minority or living in the worst quintiles of deprivation and so on. Because we know with existing screening programs, these people are very poor participants, breast screening, cervical cancer screening, for example. So I'd just be interested in any or all of the panelists' comments on how we do this in high-income settings, leaving alone the issue of how you do it in Africa, say.
This is a very, very important question, you're right. I mean, prostate cancer deaths mainly occur in elderly men. So when we achieve longer life expectancy, as we do in Western Europe, the prostate cancer mortality increases rapidly with age. Yeah. And in Scandinavia, where we have the highest prostate cancer mortality, almost around the world. Black men in some regions have worse. What we've seen is a more than 50% reduction in prostate cancer mortality due to early detection. But those men who come to early detection without a screening program implemented by the government are healthy men, rich men who seeks health care. Yeah. But we miss those men who don't have these opportunities. So I think for equity reasons, it's important that we, even in Europe, have programs that invite all men so they could have the right for early detection. I cannot say anything about poor countries. Many of them have a very short life expectancy, and I think they have larger problem than prostate cancer to deal with it in the first.
I'd urge you to read my paper because I don't think the last statement is correct at all. No, my point was, within the UK, say, the UK screening trial had only 1% of non-white participants. And so I think we may be drawing the wrong conclusions even from the trials we've done for the reason you just said, which is we're screening rich older white men and not screening people actually at most risk of premature death. And actually PSA testing may perform rather differently if we were better at enrolling such people in our trials.
But we published on that, and we saw those who were gained most from these screening studies where we invite on population levels were those men who not had their PSA before. Mm-hmm. So those were the winners of our screening trials.
So maybe just a quick comment. So Nick, I completely agree with you. I think it's a major problem about our trials not being representative of the wider population. And I think from a UK strategy point of view, you'll know the NIHR have changed their stance on funding. I think there's a couple of things we can do. The first thing is reporting by these groups, and reporting your trials by the different ethnic groups and by socioeconomic status and things will help us to understand how those results are applicable to a wider population. The second thing are, when we enroll patients in those trials, having targets for recruiting patients from underdeprived areas and from certain ethnic backgrounds, and trying to stick to those targets. You have to have a strategy for recruitment if you want to try and achieve that. And I think people should be held accountable to make sure our data is representative of all the patients we want to treat.
Completely agree. So I think in 4 years we might have APCCC screening, because I mean this is really, from a population basis, really, really important. But Jochen, what's your question?
My question addresses once more the selection of the cancers and the patient. We had a look at what cancer characteristics are and how we can identify those who might progress and where they might lead to prostate cancer specific mortality. We always ignore a little bit the host having the disease, and obviously an intermediate risk prostate cancer might be at risk for a younger patient, not for an older patient. How could we get the life expectancy in a patient or in a man into the equation for population-based screening or for decision-making when to do an MRI or a biopsy and go further with diagnostics? So I would like to have the answer from you for population-based screening, and from Vero, the one looking at the individual decision-making.
I think it's impossible to, from equity reasons, to say that if you're not healthy enough, you should not have the ability to be screened for. So I think in a screening, population-based screening program, you could put age limits, but I do not see any way not to invite men who, but this decision comes later on when they have their diagnosis and you decide whether to treat them or not, and you make individual decisions, but not at the upfront when you invite men to screening. I see no possibility to that.
So I have to watch the time. Maybe Vero, you speak to Jochen directly for the individual basis. Matthew.
Yeah, I want to come back to this question of who the right target population is. We talked about older white men, and part of the problem is older, right? Historically, we've screened men in their 60s and 70s who all have VPH. So we overdiagnose with PSA, but we also missed a lot of the lethal cancers, which should have been found 20 years earlier. So we haven't talked much about age and threshold, and as you move up to men in their 40s and 50s, as the trend is slowly doing, Of course, the threshold should be much lower. We know from Malmo and Harvard and these other cohorts, the median should be around 0.7, right? But all the trials on MRI and Stockholm 3 and all these that are coming out still work up at a PSA of 2 or 3. You know, as we have secondary testing now, whether it's MR or any of the blood and urine tests that we're not talking about today, mostly because they're only available in the US, I'm sure, you know, it seems that we have an argument to really use a much lower threshold, around 1, right, for screening at midlife. And we haven't talked about this much yet, so I'm just curious the panel's perspective, if we have pervasive availability of high reliability secondary testing, you know, it still seems like PSA is a $20 test, even in the US. It's got an extremely good negative predictive value over the next 25 years if it's under 1.0. So what is the, you know, where do folks see the trend in the future in terms of this interaction between age and threshold? And this probably applies in African populations and high-risk populations no less than it does in the West.
So I think the European perspective is that there are a lot of grant applications now underway where the screening trials are being examined with the biobanking that is attached to them to really test those tests that are not available in Europe right now, are not frequently used. So I really get the point. Yeah, okay. I think Tyler, you are next with a question, and then Michael, and then I have to present some of the open voting questions. Tyler.
Thank you. So we started with talking about preventing metastasis and death. And then, as always happens in diagnostics, and you know my group is guilty as well, we then once we get to the details, we get very worried about whether we found the grade group 2s or not. And we talk about clinically significant disease, not disease that's going to progress to metastasis, but you know, clinically significant disease. The pathology talk was excellent. We see the wonderful curves from Wen et al. So how do we functionally, as a community, as a group, move away from penalizing ourselves for not finding this questionable disease that should be on active surveillance anyway? We're good about grade group 1, but what do we do to get away from this hamstrung, clinically significant prostate cancer problem?
I think really it's a decision as a community. We have to decide whether we want to focus on the population or the individual, where we are afraid to overlook something. So it's really this distinction. I mean, some of the publications say aggressive disease, where you have grade group 3 and above, and this clinically significant. I mean, there are many definitions out. I absolutely agree with you that just saying it's grade group 2 is too inclusive. But maybe Pat can help. Michael, your perspective? Or your question?
No, I had a question. I think there was a message that PIRADS 1-2 lesion we leave alone, and then we also heard that BRCA mutations are bad. So if we have a patient coming with a known BRCA mutation and family history of prostate cancer death, and we see a PIRADS 2 lesion on MRI, do we not biopsy, or do we do some further testing?
I would not biopsy him because I know that patient is compliant. He will come back and we can delay biopsy. But that's a personal opinion. I think the data is not enough there.